Hi, I'm Keith Calligaro. I'm Chief of Vascular Surgery and Endovascular Therapy at Pennsylvania Hospital, and I'm delighted to welcome Kashyap. He's Chief of Vascular at University Hospitals in Cleveland, and an expert on the topic we're going to be talking about, and that's transcarotid artery revascularization, or TCAR, as it's better known. One of the more, I think, controversial aspects of this new, relatively new technique is will it replace carotid endarectomy, which is many people consider still to be the gold standard of carotid revascularization. So Vic, what do you think about that? I mean, some people, I think maybe some of the old guard feels that carotid endarectomy is going to stay the best operation for the foreseeable future and maybe 10 years from now. But others feel that the results of TCAR are very promising and might replace it. What do you think?
So you'd probably expect me to give you the answer that TCAR will replace carotid endarectomy, and I will say that I've become an enthusiast of the procedure, but I think the answer is a bit more complicated. I do think for patients that are high risk, TCAR has really become a phenomenal alternative. But standard risk patients, it may be a different situation. And also, I think the one thing we really don't understand still is the morphology of the plaque. So in patients with the really atheromatous plaque, where we're really worried about embolization, even though I do believe that reversal of flow system prevents embolization, it may be still that carotid endarectomy is the best option in some patients. That being said, now on a multi-institutional review that we wrote with 4 institutions of close to 300 propensity-matched patients with carotid endarectomy, VQI data, which is now numbering in the thousands, and the soon-to-be-released Roadster 2 study with nearly 700 patients undergoing TCAR, the results have really been almost analogous to the results with carotid endarectomy.
What are the advantages of TCAR specifically in relationship to surgery?
So it's a small incision. It is still an incision, but it's one that heals extremely well. It allows you to get access to patients, or not patients, but to lesions that sometimes would be challenging, that are very high lesions, perhaps in the neck, perhaps in patients with a lot of radiation injury or other previous surgery, and perhaps most importantly in my practice, restenosis, which I'm seeing as a referral center from other sites and other surgeons. Okay. I do think the other big advantage that we've shown is there's a virtually zero cranial nerve injury rate, right. Which we like to say that with carotid endarectomy it's close to zero, but in fact in the trials that have looked at this closely, it numbers anywhere from 1% to 3%.
I've been so impressed by the data you guys have published and others that the results have been shown to be at least as good as open surgery, but in higher risk patients. That's who's been getting it. So if you apply it in general across the board, and I'm not saying everybody with the dense calcified lesions, I'm going to go out on a limb here and predict in 5 years TCAR outpaces carotid endarectomy if people are willing to adopt it. Now, there's going to be a lot of people who just struggle with learning a new technique, but I wouldn't be surprised, to be honest.
So we have two papers coming out on learning curve, which is something that I'm very interested in. One that just came out in the Journal of Vascular Surgery, and an upcoming one in the Journal of the American College of Surgeons. And what's amazing about this novel technique is the adoption of that technique occurs, and the learning curve is very short. That is, within a few cases, anywhere from 3 to 8 cases, a surgeon is an expert at this procedure. In fact, surgeons that had less than 5 case experience versus surgeons that had greater than 30 case experience, they had similar outcomes in stroke, right. death, and myocardial infarction. The only difference was a slightly increased bleeding risk in the early cases. So it's a very resilient procedure, right. Fairly easy to learn, fairly early to master, and then for the patient, a safety profile that even early in the experience for the surgeon, there's no deficit.